Okay. Well, thanks for staying to the bitter end. Our debate is the final of the day before the cocktail hours. That's a challenging place to be. And this is the title of the talk that we were assigned. When I wrote this, I saw in the program that it said this: patients with VT should get an ICD even if ablation is successful. And I sort of panicked, and I called or emailed Ed, and I said, wait, I thought it was patients with tetralogy of Fallot. This is not fair because not all patients with VT. And he said, well, you could just argue everyone should get an ICD. But we'll stick with patients with tetralogy of Fallot, and a successful VT ablation should still get an ICD. Here's my disclosures. And the intimidating Dr. Zeppenfeld is going to give you the con to this. And she's impressively, is a vice chair and program director and speaks internationally, speaks in multiple languages on this. And, so, yeah, I've been to Holland too. So, so we're going to talk about the rationale for why everyone should get an ICD. And the first is the risk of sudden death. And Ed put this together a while ago on multiple articles on the incidence of sudden death after repair of tetralogy of Fallot. We all know that there's that risk. That's why they get ablations. That's why they get ICDs. And, ranges, but on average, about 2% per decade of life. And they're living multiple decades after their tetralogy repair. So that adds up, and it's a significant risk. So after many, many years, Ed's paper on the case-controlled study of VT and life-threatening events in repaired tetralogy of Fallot with Joe Atala and other members of the Pediatric EP Society put together cases with the 1 to 3 controls looking at risk factors. And there's a whole bunch of risk factors. They're difficult to distinguish, but if you look at the sort of the typical yellow is a medium risk factor and red is a high risk factor. So ventricular dysfunction, in the early days, the presence of a shunt prior to complete repair, RV dysfunction, a transannular patch. If they didn't get a transannular patch, that's more of a risk. But specifically, if they have arrhythmia symptoms, was the highest risk. And we know those patients are at risk. We know that ICDs can provide both pacing, anti-bradycardia, anti-tachycardia pacing, and a defibrillation shock. So they're proven effective treatment for ventricular tachycardia and prevention of sudden cardiac death. I don't need to argue that point. And we know that in tetralogy of Fallot patients, there continues to be an ongoing risk of VT and sudden death. And this study of tetralogy patients with ICDs, you see by about 10 years after implant, so the lifetime of one ICD generator, about half of the patients had an appropriate ICD shock, particularly the ones that were put in for secondary prevention. But even the ones for primary prevention still had about a 7% per year risk of receiving an appropriate shock. And so we need to treat them. So what do we treat them with? Catheter ablation. So with either radiofrequency ablation or cryoablation, we're treating what Dr. Zeppenfeld is going to tell you are isthmuses. And we're going to treat these isthmuses with catheter ablation. And so with either RF or cryoablation, will this be successful by doing these ablations, substrate ablations? Well, let's look at the data. Going way back to the 20th century, when Jim Morwood was with us in Boston, looking at basically all the pediatric congenital VT ablations, 97 ablations in 62 patients with an acute success rate of 60% on an intention to treat analysis. And I think this was one of the most honest papers out there. It's not reporting 100% success rate, and it really highlighted some of the challenges we've had with VT ablation. Some of them were not mappable. Some of them were not in safe locations. And so even if you looked at those, there was the ones that were acutely successful, a third of them had recurrences. And even after 1 to 4 ablations with an average of 1.9 ablations, the success rate was only 61%. It got better if you only counted those that had mappable VTs in successful locations. So this was, I think, an important study out there. And it was, 20 years ago. So even recently, that data, that the statistics are consistent. So in this paper, recent paper from Beijing, they looked at 20 patients with repaired tetralogy Fallot and VT, and again, an impressive 95% acute success rate, so 19 out of the 20 patients, but 30% had a recurrence within 1 year, including, if I do the math right, 5 of those 6 recurrences were hemodynamically unstable, potentially life-threatening. Dr. Zeppenfeld herself is on multiple papers talking about the risk of sudden death with ventricular arrhythmias and tetralogy, and her landmark paper there in Circulation in 2007 on catheter ablation also clearly mentions the recurrence risk. And she put out a nice diagram here that is sort of an algorithm for how to manage those patients. And you don't really need to read every single line. Just look that right in the middle, it says ICDs are the center of importance, and everything around it says yes. So basically what she's saying is everybody needs an ICD. If you look at the ESC guidelines that she was the chairperson of and the HRS ERA guidelines, there's clear recommendations of ICD therapy in congenital heart disease patients. The recent PACE's HRS expert consensus statement on this was also quite clear. There's 3 lines in there. Class 1 indication that catheter ablation is indicated as adjunctive therapy to an ICD in adults with CHD and recurrent monomorphic ventricular tachycardia. I think that's pretty clear. It's adjunctive therapy. The Class 2 indication that catheter ablation can be considered for symptomatic sustained monomorphic VT, highlighting in adults with congenital heart disease and ICDs as an alternative to drug therapy, but not instead of an ICD. And catheter ablation alone is not considered appropriate prophylactic therapy in adults with congenital heart disease that are considered at risk for sudden death. So the guidelines are pretty clear that ICDs are still indicated even after ablation. If you don't believe that, let's believe a paper that Dr. Zeppenfeld was a co-author on, and many of the authors are here at this meeting. And I'll quote, "While the mechanisms of scar-mediated reentry VT along slowly conducting critical isthmuses have been uncovered and can be successfully ablated, it remains unknown if proactive ablation can prevent VT and sudden cardiac death or simply serve to decrease the arrhythmia symptom burden." And if you don't believe Dr. Zeppenfeld, always believe Dr. Walsh in his paper about the role of ablation therapy for VT in patients with tetralogy. And he says that ablation therapy, whether performed in the operating room or the EP lab, is rarely used as isolated therapy in the present era. It can play an important role in reducing the shock burden for patients who already have an ICD in place. But reliance on ablation to prevent sudden death in high-risk patients with tetralogy without a backup ICD seems ill-advised. And when Ed says ill-advised, I wouldn't do it. It's really a balance of risk versus risk. I'm quoting you. It's a balance of risk versus risk. There are risks to having tetralogy and VT. Catheter ablation can be curative in many, but not all patients, and we cannot yet fully predict who will recur and who will have sudden cardiac death. We know that ICD therapy is safe and effective as a life-saving backup plan. So on the balance, the risk of the ICD is lower than the risk of VT and sudden cardiac death in tetralogy of Fallot. To summarize it pictorially, if you don't have a backup ICD and you get VT recurrence, you end up with VF and sudden death. If you have a backup ICD, you end up with a life-saving shock. So the second one in this debate to use a minion. Thank you.
So thank you very much. So I have no disclosures regarding this presentation, but I'm not completely sure about Charles Berul because I think there is some bias towards more interest in ICDs if you compare with VT ablation. But nevertheless, I wanted to broaden the topic a little bit and start with, in general, life-threatening arrhythmia, and these patients should get an ICD even if ablation is successful. So this is a FBI, a fast broad irregular tachycardia, a patient with accessory pathway and atrial fibrillation and a fast ventricular response. And in these patients, VF can occur, and I got this slide from Nico Blom. This was fortunately only in the lab, so a patient with accessory pathway, atrial pacing, induced AFib, fast ventricular response, and then VF. So this patient has a clearly defined substrate, which is an accessory pathway. And we are able to identify this substrate during catheter mapping in the lab. And we have a very nice, well-defined and measurable endpoint of successful ablation, which is actually bidirectional block across the accessory pathway. So who on earth should implant an ICD in this patient after successful ablation? Probably no one would do that. So let's have a second case. This is a 28-year-old patient with tetralogy, clinical VT, 260 beats per minute. He was repaired early with a atrial transpulmonary approach. His ECG, right bundle bench block, QRS 144 milliseconds, no fragmentation, MRI, good biventricular function, little bit enhancement projecting on the VSD patch and at the infundibulum. So important now, what is the substrate of these VTs, and I can probably keep this short because we all know the macro-entry mechanism of VTs in tetralogy of Fallot, and I like this image a lot because it shows this macro-entry circuit around the RV incision. But if you look closely, this VT is usually actually two anatomical isthmuses between the RV incision and and the incision and the pulmonary annulus. And these are the anatomical isthmus 1 and 2, and later we have described 3 and 4, 3 between the VSD patch and the annulus, and 4 between the VSD patch and the tricuspid annulus. However, with a modern approach, like in our patient with a transatrial transpulmonary approach, we don't have anatomical isthmuses 1 and 2 anymore, so everything is probably limited to anatomical isthmus 3. And this is the case in our patient, so this would be the anatomical isthmus. He had a perimembranous VSD, and the VT morphology is consistent with the exit site at the infundibular septum. So we performed mapping in this patient, showing that the entire ventricle was fine. So there's a voltage map in purple. Everything is, if you want, healthy. And we only had this abnormal area between the VSD patch and the pulmonary annulus, which is anatomical isthmus 3. And we could show that this was an area of slow conduction. And if I show you the propagation map on the right, you see already this eyeballing during sinus rhythm. This is the only area which shows abnormal activation during sinus rhythm. And we could ablate this area by a linear lesion connecting the pulmonary annulus to the VSD patch. And we have hard endpoints of ablation, which is non-inducibility. We use a very aggressive simulation protocol on the left, which is going down to refractory period with 4 extra stimuli and using isoprel, if not inducible, with this protocol. And we have a clear endpoint of ablation, which is not only the non-inducibility of the VT, but bidirectional conduction block across the ablation line, which is proven in the lab by pacing from 2 directions, what you know from carbotricuspid isthmus ablation. So now we have a life-threatening arrhythmia. We have a well-defined anatomical substrate in this patient, only anatomical isthmus 3, which we can connect with the ablation line with a well-defined and measurable endpoint for ablation, which is bidirectional conduction block. So why should we implant an ICD in this patient? Probably we should if there's an indication for primary prevention of sudden cardiac death. So it's substrate independent or an extra substrate, but it's not related to the anatomical isthmus which we have just successfully ablated. So if you look a little bit at the risk stratification in Fallot patient, because now it's more about primary prevention of sudden cardiac death and not about treatment of VT, then we have some data. This is a paper from Paul Curry dated back in 2008. And he looked at 121 patients with tetralogy implanted for primary or secondary prevention. The ICD before 2006, the age at ICD implantation was 33.3 years. So most likely, most of the patients were actually operated in the early area with large ventricular incisions. If you look at the prime prevention population, so 68 patients, and these patients were mostly symptomatic. They had near syncope or syncope in 63%, and then they had these classical risk factors so like QRS widths, non-sustained VTs, low ejection fraction was rare in this series, and inducible VTs in 41%. And these patients were considered to be at risk, and actually they were selected quite well because the annual risk of ICD shocks was 7.7% per year. However, the annual risk of ICD shock does not mean that they would have rescued a sudden cardiac death, because if you look at the secondary prevention group in this study, the majority had a non-fatal monomorphic VT. Nevertheless, they developed from this prevention group a risk score for upper ICD shocks, and they found if there are a couple of this risk score is between 0 and 2, there were no events. If the risk score is immediate between 3 and 5, the annual rate of appropriate shocks was 3.8%, and if there are 6 or more, the risk score was 6 or more, then it was quite high with 17.5%. So looking at our patient, he had no prior palliative shunt, he was non-inducible after ablation, the QRS duration was narrow, and he had no ventriculotomy incision, which is a matter of fact in most of the contemporary patients with tetralogy or Fallot. They simply do not have these risk factors anymore. Our patient had non-sustained VT and normal end-diastolic pressure, so our patient had a risk score of 0 and would probably not qualify for ICD implantation. Similar, and this study has already been shown from the French group, they also have looked at their Fallot population. The French Society ICD implanted since 2000. The patients were older than in the Carey paper, so overall it was the same era of Fallot operation and very similar the risk, so 7.1% per year ICD treatment in those implanted for primary prevention, and also quite similar the risk factors that have prompt ICD treatment, so syncope, symptomatic patients, QRS duration of 180 milliseconds or more, non-sustained VT, reaction fraction of 35% or less, and inducible VTs in 71%, however, only half of the patient underwent actually EP study. So if you look at the risk factors that are also promoted in the guidelines, none of the risk factors was independent associated with ventricular arrhythmia rates, but if you have additional risk factors, then the annual incidence of ICD therapy was indeed higher. So of importance, they also included QRS fragmentation as a new risk stratifier, and this was actually the only factor associated with appropriate ICD treatment in univariable and multivariable analysis. So if you look at our patient, the risk score was 0 and has no QRS fragmentation. So again, based on this data, there would be no assumed risk for sudden cardiac death. If you look at the guidelines, indeed, this is the management of adult congenital heart disease guidelines from Europe or from the US. There are this risk factor mentioned, and if they are present, then it's a 2A indication to implant an ICD. In addition to the non-sustained VT, QRS duration, and usability, there's LV systolic function and extensive RV scarring. And in the last ESC guidelines, we have also included the severe QRS fragmentation as risk factors, and we also emphasize the importance of inducibility of VT as a risk stratifier for primary prevention ICD indication as a 2A. So coming back to the RV scarring, this is a risk factor which is mentioned in all the guidelines. And this is the first study, to my best knowledge, which has tried to quantify in a way the RV scarring in the RV. This is from the Roy Brompton. They have performed LGE CMR in 550 patients. The scan was performed between 2002 and 2019, and the patients were at median age of 32 years. So certainly there are more patients included that were operated in the modern era. And the ventricular arrhythmia rates were in general low. 5.3% had a ventricular arrhythmia event during a follow-up of 6.4 years. And more than half of the patient had again a non-fatal monomorphic VT at presentation. So they have developed a quite complicated system to quantify the RV LGE. They use the different segments and the involvement per segment, and came up with a weighted risk score, so using all variables that were associated with ventricular arrhythmias in univariable analysis and were not related to each other in bivariable analysis. Of importance, the classical risk factors were not associated with ventricular arrhythmias, again like QRS duration and non-sustained VTs, but also not inducibility at stimulation, but they only performed with stimulation in 12.7% of the patients. So the risk was pretty much, or the risk was in particular driven by moderate and severe extent of RV LGE and severe RV and severe LV dysfunction in this study. Of interest, they concluded that they have identified a high-risk group of patients who have an estimated 4.4% annual risk of mortality and a 3.7% risk of ventricular arrhythmias, who could be considered for primary prevention with ICD or VT ablation. So our patient had a risk score of less than 20, and he would not be even identified as being at risk for ventricular tachycardia, and certainly not for ICD implantation, but this is probably another debate. So why should our patient should get an ICD? These are our data from Leiden looking at follow-up of patients who underwent EP study and electroanatomical mapping. And this is probably quite representative Fallot population with a majority having a preserved biventricular function. And if you look at our mapping data, these are the patients actually in green who had no slow-conducting anatomical isthmus, but also no other substrate for VT. We had no events during a median follow-up of 58 years. If you look at in blue the patients who had ablation success, so bidirectional block across the line, there was one event in a patient with heart failure. If you look at the right, these are patients with a biventricular preserved function. There was no event of any ventricular arrhythmia during follow-up, which is different, of course, if we fail to transect anatomical isthmus. These patients have a high risk to recur or with ventricular arrhythmias or experience a ventricular arrhythmia. So I think that in our patients, there are no data to support ICD implantation, but we expose the patients to the harm of ICDs because ICD-related complications are significant. This is from the circulation paper from the French group, 8.7% per year ICD-related complications without any benefit from the device. So my opinion is after successful ablation of a well-defined VT substrate, TETRALOGY patients should not get an ICD, only if they have a primary prevention ICD indication, so a second substrate for life-threatening ventricular arrhythmias. Thank you very much.
While he's looking, I want to admit that just so people don't think I would not put an ICD in everybody who had a successful VT ablation, but I'm doing the part of the debater and trying to convince you.
That was a very effective strategy.
Yeah. Yeah, no, but the point is, though, there are patients with tetralogy and VT, and there are those who have successful ablation of VT. And as I said, in the early days, before learning substrate ablation from Dr. Zeppenfeld and others, the success rate was only about 2/3. And as we got better and learned about that, with rather than having a third recurrences, as ablation got better, the recurrence rate went down. But it's not zero. There are some patients who don't have successful ablation of VT, and it's difficult to tell, even if it's a much smaller fraction, who those are going to be. And so I showed this before, and it really is a balancing act. If you don't have a backup ICD, you have to make sure that that's a patient who doesn't have a continued risk of VT, as Dr. Zeppenfeld said, either a secondary substrate or some other reason why they're still at risk for VT. And there are some recurrences, and you have to make sure in your lab that your data is good as your 5-year follow-up data. So a backup ICD is there for your patient's protection in those cases of whether they're still at risk. Here's the things I like about the Netherlands. And Dr. Zeppenfeld is on there as one of the things I like about there. Legalized marijuana is on there, cheese. Anyway, so thank you, and that's my simple rebuttal.
I just keep this slide because I have no rebuttal slides and I like it a lot, so we can keep it also for the rebuttal. Now, I mean, I agree if it comes to, and of course, there is a recurrence risk in patients with VT, and I really acknowledge that. And therefore, what we do actually as an additional strategy, if patients with a Fallot in a Fallot population have very fast VTs, and we do an ablation, we now perform remapping to see that we have durable lesions. Because I think the concern, and I completely agree on that there is recurrence of conduction in every ablation we do. So we have to be sure that this is a durable lesion. And if patients present with relatively slow or very well tolerated VTs, this is probably not such important, because if they have a preserved function in no other substrate, we are confident that probably also with a VT recurrence, this would be not a fatal episode. But with fast VTs, we have to be sure that we have durable lesions and bilateral conduction block also during follow-up. But still, in these patients, I still would not implant an ICD.
So thank you. I think you took away already the conclusion. It's a bit interesting that you know, I think you didn't get the really what you should do in a debate. You know, you should try to win. Next time, we should threaten you to take away the vouchers for the drinks afterward, to get more fight. But I think in the end, of course, we do that to get to a conclusion. I think the conclusion was already there, which is great. I think, is there anything anyone has questions maybe for the debaters or anything? We have a few more minutes, or everybody wants to go to the drinks?
I was just wondering, when you have a tough patient with an ICD implanted and they get arrhythmias, is there data after an ablation? What's the proportion of VF and VT? I mean, is that mainly recurrence of the VT, or do they just have the progression of their substrate and then get VF?
I think it can be good. It's a very good question. I think they could have either one. They either have a recurrence of their monomorphic VT, or they have another reason why they're at risk for sudden death from VF. And I can think of one patient I had who I did what I said I was going to argue here. This probably 20 years ago. After a VT ablation, put an ICD in him, never used it, had a battery elective replacement indicator, put a new generator in, and then probably 15 years later, he had an inappropriate shock for lead failure that put him into VF and then got shocked out of it. So there's definitely some reasons to not put an ICD in, but you know, you have to be confident that they're not at risk for VT. So it really is a tough balancing act, and you can lose either way.
In our database, at least, so the VF episodes we had in Fallot patients are those with really biventricular failure, usually LV involvement, and also usually a low LV ejection fraction. So I cannot recall a single Fallot patient where we had monomorph VTs and a preserved function with any VF episodes. They recur with fast VTs if we are not successful with ablation. And of course, the fast VT can also be fatal in certain circumstances. And this is actually a matter of fact in the Fallot population. So you have to be sure that you really have a durable subset ablation in these patients. Yeah.
Or flutter with 1-to-1. That's the other.
Can I?
It's very difficult to answer, because I think that the atrial arrhythmias, so if patients are going older, I don't know if it's just a double tachycardia, that you just have a flutter with high ventricular response and you get in a ventricular tachycardia. There's always a discussion if it's just double tachycardia or one is inducing the other. And so it can also just be an association, but not really a causal link. So it's always a little bit the question, if you have two arrhythmias which are both present in this patient population, if it's just an association of the atrial arrhythmia with a ventricular tachycardia or sudden cardiac death.
Yeah, I think I'm going to quote an article that you're the senior author on, and you put me on as a co-author. But you know, there's about a quarter of them, right? A quarter of tetralogy patients have atrial flutter. I think you wrote, and but many of them it's 1-to-1, so they can conduct it rapidly. They've got atriotomy scars and other reasons that they may get atrial tachycardias, but they can conduct more rapidly than you would expect. They've got very healthy AV nodes.
Okay, there's one more question there. I might just ask one question too. Do you, for follow-up, what do you do Because I think that's the most important thing. As you said, it's a moving target, you know. You ablate one VT, that's true, but it's evolving, you know. This patient is going not always downhill, but do you put in event recorders, or do you follow them up regularly?
I'm not so sure about the evolving substrate in this patient population, and I probably would debate this a little bit. So I think, so my personal I think is that in patients that are operated more recently, so where you don't have this RV incisions, and in patients that have on MRI not additional lesion like ischemia during operation or other reasons for scar in the ventricles, I think that this anatomical isthmus 3 area is just prone to remodeling. And we see this also, we also do the preoperative mapping in children, and you see very often already that there is some slow conduction. We have now the first remaps done where you see in after 6 or 7 years there's something happening in this particular area, but not in the rest of the ventricle. So I think if you have ablated it, why should it, even it recurs because you have not sufficient lesion, but why should other areas in the ventricle remodel over time? So with the exception if there are new severe hemodynamical sequels or other new lesions, all these patients are just older and get acquired heart diseases and are therefore at risk for ventricular arrhythmias. But in our patient population, even in the older one that have this area, have only these areas and no other areas in the ventricle which give rise to ventricular tachycardias, at least not in our mapping and induction studies.
So those are great talks. And Charlie said there's instances where he would ablate and not put an ICD in. Is there ever an instance, Dr. Zeppenfeld, where you put an ICD in and not go after the substrate? Do you ever just say, you know what, this one's too risky, I'm just going to put the ICD in, and then maybe down the line do an ablation? So
you mean in patient where we have been successful and to still would say, we give him or her an ICD?
They come in with a fast VT, they've passed out, you look at they've got a low EF, they've got a high EDP, they've got all the EQ restoration is 220. Would you just say, I'm going to put an ICD in and not ablate?
No, I would always give it a try, and I always would like to make sure that the VT, which is documented, fits with the substrate we find. And if we can ablate the substrate, actually the fastest VT I've ever seen in a Fallot patient was 290 beats per minute, and she still entered the emergency room, and we ablated her. This is typical substrate. We sent her home without an ICD. It's more than 10 years now ago. So we still are quite confident if we see that this is a substrate, because the VTs in tetralogy, they are typical that fast, in particular in young patients. They have a very small, shortcut. Then you have a small area with slow conduction, which is different from the post-infarct VTs. But if you are confident that you get a bidirectional block in this area, and this area is really eliminated, and you do a remap a couple of months later, and it's still bidirectional block and non-inducibility, I would feel quite confident that this has fixed the problem.
But if they had other risk factors, if they had the fractionation, was there ever instance you'd just go right to the ICD and not ablate if they had all the risk factors to say she's for primary prevention?
The question is, are our risk factors we have, are they sufficient to identify the VT subset in these patients? I don't think so. Okay. I think that the risk factors we have in the past, they reflect the RV incisions, they reflect probably the remodeling of the poorer function. The QRS fragmentation is very interesting, and we now look in our mapping data to see if we can link the QRS fragmentation to our mapping data, because there's just change of activation wavefronts which also give rise to fragmentation, and they can be just due to the isthmuses, if you we look in this. So I think that the fact that someone presents with a VT is of course at risk already, and then you have to decide, can you ablate this without any additional substrate or not? So, but I would never put an ICD without doing the mapping and give it a try to ablate it. And we don't need, in this patient, the additional risk factors, because we know already there is a VT here and the substrate to sustain VT.